fine silk coated with Vaseline to complete the vessel repairs. And he got noticed by Halstead and Cushing at Hopkins. They had him come and speak there, and he anticipated organ transplantation, and he presented his work on the replantation of canine limbs. And in 1912, he was awarded the Nobel Prize. Then the first operating microscope was used by Nyland for the ear. In 1954, Carrel's prediction came to life when Joe Murray did kidney transplant at the Brigham. I knew Dr. Murray in my residency. He actually became a plastic surgeon. Then Jacobson and Suarez did the first microvascular surgery on a rabbit's ear. And then Ron Malt at the Mass General, who I also knew in my residency, and he became the abdominal surgeon, did the first extremity replantation. And in 1965, Komatsu and Tamai did the first thumb replantation, and that opened distal extremity replantation. Now, this is Everett Knowles when he was 12 years old. He was the first replantation at the brachial level. And when I was a resident at the MGH, he was still bouncing around the orthopedic clinic. So for replantation, as we know, it's the same zones as Verdun's flexor tendon zones. The indications generally are the thumb, multiple digits, single digits in zone 1, hand, wrist, forearm, or arm, and just about any amputation in a child. The contraindications in most cases, not all cases, are single digit zone 2, comorbid state, they're too sick to undergo it, self-mutilation, although I have replanted a hand on someone who took his hand off because voices told him to with a power saw. Significant crush injuries, complete ring avulsion injuries, and prolonged ischemia. Operative sequence is pretty straightforward. It's not written in stone, but you identify the vessels and nerves, debride and clean parts, shorten and debride the skeleton, fixation, tendons, arteries, nerves, veins. Veins are easier to repair after they've got some blood flowing through them, and skin closure. Now, when I first went into practice in 1987, I was the only hand microsurgeon between Atlanta and Gainesville, Florida. And I had a significant early experience, and we looked up my first 6 years, and I did 48 replantations and 39 patients, 6 with multiple replantations, range from 4 to 69 years, but of interest, 7 of the patients were less than 16 years. The levels replanted are noted on the left. And you can see that my numbers got better. My percentage of success got better. 1988 to 1990, I had a 43% success rate. 91 through 93, I had an 85% success rate. 1989 was a bad year, and I'll show you why. Here's why. This 4-digit zone 2 came to me floating in warm saline, and you know what it takes to put those back on, and I just never got it to fly. So no reflow phenomenon. The other thing I'm going to try to do is I'm going to show y'all, I'm going to speak up when I see things that I've seen on examinations, because there are a lot of them, and this is one. But it's failure of blood to reperfuse ischemic tissue, and it's proportional to ischemia time, and cooling extends the ischemia time. It's associated with endothelial edema, arterial vasoconstriction, platelet aggregation, oxygen-free radicals, and acidosis. Now we're going to start at the tip and work proximally. Zone 1 amputations, Dr. Urbanik, Nunley, and Goldner and Stevanovic sort of said it here. The advantages are that it is a one-stage procedure that gives good distal soft tissue coverage, adequate sensibility without painful neuroma, good MP and PIP motion, preserves the nail, maintains digit length, is cosmetically pleasing, and the patient is satisfied. When it can be done, it's a good procedure. Now, Sebastian and Chung published this in PRS back in 2011, where they broke the distal replantations into zones. Zone 1A is distal to the lunula through the sterile matrix. Arteries very difficult, veins impossible, and nerves impossible. 1B, between the lunula and root of the nail through the germinal matrix, artery is difficult, vein and nerve are very difficult. 1C, between the FDP insertion and neck of the middle phalanx, arteries easy, veins difficult, nerves easy. 1D, between the neck of the middle phalanx and the FDS insertion, easy, easy, easy. So here's an easy, easy, easy. This is a zone 1D, power saw injury. You can you note that there's significant shortening of the amputated part with the difference in circumference as well as the difference in length of the replanted part. But the patient's very happy. He has an FDS finger, and it's a good case. Thumbs are always a blessing when they work, and we know the importance of the thumb to the hand. And this is just one. This one's interesting because the guy he had this injury, and then they brought him to the hospital in another town, and then they shipped him to see me. And then they realized they'd left the thumb at the site of the injury, and so had to go find it and bring it. But it worked out. So then you have the zone 3. This is a 34-year-old industrial crush injury. The index finger was a segmental injury and was not replantable. So in this, I don't have his X-rays, but I use little Synthes metacarpal plates for him. But when you have this amputation through the middle of the hand, you're right through the intrinsic muscles, and you'll never get those intrinsic muscles back. And so in this case, in order to give him opposition, I did PIP joint fusions, arthrodeses. This is one, I always say if I only did one case in my career, this case made my training worth it. And this young girl at age 4, by the way, she is the granddaughter and niece of neurosurgeons, no pressure there, had a golf cart her brother was driving her around in, amputated her hand. And I did the replantation. There was a significant crush. I heparinized her, and 24 hours into it, I was monitoring her with a pulse ox. It quit, and she had a palmar hematoma, went in, got hemostasis, and after that, she never turned a hair. This was when she was 4 years old. She called me in October. She's graduated from college now. She went to the University of Georgia. And she says, calls me, Dr. Waldo, will you talk to me about what happened to me when I was 4 years old? I really don't remember a lot of it. And so she came in and we met, and as opposed to the other case, look at her intrinsic function. It's just amazing. You just can't hide youth. And there she was with me a few months ago, and it's as I say, it's a career highlight. So here's a hemi hand amputation, also an industrial accident, and this one of the points I make here is do a primary proximal row carpectomy. You get shortening. I did not. I just used Steinman pins for internal fixation. Got primary healing, and then came back and did a wrist arthrodesis, and thumb, index, and middle fingers work well. The little fingers just kind of there. But now this shows the point about youth. This is the same injury. The top's in a 6-year-old who went into his dad's shop. Well, no one was at home. Turned on the power saw, cut off his hand. Called his dad, said, "I've cut my hand off." And anyway, there's that. And then the second, there's a patient with an intrinsic minus hand at age 46 with really no function. Now, this is a crush injury from a pickup truck. This is a 4-year-old, as I say, a lot of kids. And he came in with hanging on the nerves. The nerves were intact with this significant crush injury. And so I did this case with a scrub nurse. You know, that's kind of hard for me to believe looking back on it. But I was young and full of ambition, P and V. But shortened the humerus, did a significant debridement, saphenous vein grafts to the artery and vein. Then I had this big hold, and I rotated over the pec major to cover it. And this is one of the most important things. If you ever have a case like this, do the fasciotomy before they leave the operating room, because he swelled up. I mean, that ischemic hand and forearm would I would have either had to take him back, or it wouldn't have worked without the fasciotomy. Came back later and did skin grafts, and at age 18 he entered the armed services. He did have some loss of motion in his elbow. I later did a Z-plasty in his antecubital fossa. So ring avulsion injuries. They're usually in the left ring finger. They've been urbanic in JHS in 1981, divided these into 3 classifications. 1, circulation adequate. Those are the ones you put a stitch in and send home. Type 2 is a circulation inadequate, which is vessel repair. And type 3 is a complete degloving. The board answer for that is ray resection. Then the guys in Louisville came along a few years later and added another type 3, where there's inadequate circulation with bone, tendon, or nerve injury. They say amputate. And then type 4 is a complete degloving, of course, which would be urbanics type 3. Now, this guy was in not long ago, and he had the Louisville type 3, where he had complete degloving of the dorsum of his finger. He absolutely refused amputation. He had arterial inflow, and I leached him. And you see, he's got a small finger, but he's happy with it. And he had this big slough over the dorsum. So here's another question: how do you cover a dorsal PIP wound? Well, one way is this reverse cross finger flap. You deepithelialize the soft tissue. You fold over the subcutaneous tissue, and then you skin graft it. And it's a good trick to have. Of course, there are other ways to do it with island flaps, kite flaps, and so forth. But this is a good arrow to have in your quiver. Okay, here's an urbanic class 3 ring avulsion. You treat those with a ray resection. And as I said, I have used leeches when conventional procedures fail. This one made the AP. And this is these questions you'll see on test. So the medical leech is Hirudin medicinalis. Okay, what does Hirudin do? This is a test question. It inhibits the procoagulant activity of thrombin, blocking conversion of fibrinogen to fibrin. The histamine they secrete is a vasodilator. Hyaluronidase increases local tissue permeability. The proteinase inhibitors that inhibit platelet aggregation. And of course, the most common bacteria is the Aeromonas hydrophilia, and do prophylaxis with trimethylene sulfur or fluoroquinolone, third generation cephalosporin. And if you have no veins repaired in a replanted part, it's 7 days of leaching. So that's enough replants. Now we're going to talk about free tissue reconstruction of the hand and forearm. Obviously, it's coverage of vital parts and functional restoration of missing parts. So the advantages are single stage, multiple design possibilities, elevation of the recipient site, and unique alternatives for specific needs, such as a great toe for a missing thumb, etc. Now, if you know this slide, you'll get questions right on the American Board of Orthopedic Surgery hand certification. You'll get questions right on self-assessment exams. But the subscapular artery, I saw a test one time, test question where it was the watershed vessel for a number of flaps and they would have some distractors, including the thoracodorsal, but the right answer is the subscapular artery, branch of the axillary artery, and branches of the subscap are the thoracodorsal. We know what that's the pedicle for the latissimus dorsi. The branch of the thoracodorsal, the serratus branch, is the pedicle for the serratus anterior. And then you have the circumflex scapular artery, which is located in the triangular space. And its descending cutaneous branch is the pedicle for the parascapular flap, and its transverse is for the scapular flap. So you sorry. Everybody's got that, right? Okay. Okay, so here's just a review of the posterior shoulder spaces. There's the circumflex scapular flap in the triangular space between teres minor, teres major, and the long head of the triceps. The triangular interval has the radial nerve and profunda brachii. We all love the quadrilateral space with the axillary nerve and the posterior humeral circumflex. Okay, so I cut my teeth on cotton mill injuries, and they're gone now. But the cotton mills are gone. But they created wounds that required creativity and challenge. So this is a carding room injury. You can see the carding room are metal teeth that comb the cotton. And you can see the little serrations of the comb here. So, all right, guys, how would y'all cover this one? Any thoughts on coverage for this injury? You have this full tissue loss over the breadth of the hand with extensions out onto at least 3 digits.
Chrissy, how do you go?
I think it would be too big for like a PIA. You could do like a radial arm flap also.
How you can deal with those defects down to bone out on the fingers?
I mean, that one finger looks like it's needs.
No, good neurovascular structure, just a little problem with the DIP joint.
Okay, then I would pin that DIP joint or fuse that DIP joint.
Yeah, fuse the DIP joint there. And how do you cover the wound? Any thoughts?
On the fingers.
What's that?
The just the one on the fingers you're saying?
The whole thing. How would you cover it?
Well, I mean, I've seen people do like they just like take the rest of this like interval skin off and then they just cover the whole thing with the groin flap and then like they create webs.
Yeah,
like,
well, that's good. That's good. But Paul, you got a thought on this one?
Yeah, it's a big one. One out of the fingers is hard because you put just a big sheet of a flap on there and then you're having backwards. You do that, but it just that's trouble. You can do a parascapular flap or something like that, or a latissimus or a serratus. You can split the serratus.
That's the right answer. That's the right answer. We did the serratus flap.
That's why it's free, I thought that.
Serratus flap based on the serratus branch of the thoracodorsal artery. It's the lower three slips of the serratus, and those little striations are just made to go out on the finger. And there you go. And and then obviously covered with the mesh graft. You can see the Doppler where the pulse is, and this healed well, but the patient developed this severe scar syndactyl. And I'll show you in a minute how we dealt with that. Okay, there's also the femoral artery watershed, which is, of course, the superficial circumflex iliac is a pedicle for the groin flap. And then the profunda femoral has a descending branch of the lateral femoral circumflex for the anterior lateral thigh flap, and then the gracilis, the medial circumflex femoral artery. And here's I know y'all talked about flaps recently here, but here's the anterior lateral thigh flap, 38 by 12.5 centimeters, thin flap with a pedicle between the rectus femoris and the vastus lateralis for the descending branch of the lateral femoral circumflex artery. I recently used this artery on a patient who 15 years ago, I'd done a forearm vein graft for ulnar artery thrombosis and came in with aneurysmal changes, throwing clots distally, and went in and resected the thromboaneurysm and interposed this artery, and it worked well. So the two arteries, when you need arterial grafts, the two best donors for hand reconstruction are the thoracodorsal or this descending branch of the lateral femoral circumflex. Now the groin flap, we all know, it's a workhorse flap. The superficial circumflex iliac artery, they'll ask you that on every exam you take. They'll also ask you what fascia you raise with the flap, anterior sartorius fascia. So here's the groin flap. The pedicle is 2.5 centimeters beneath the line from the symphysis to the iliac crest. And you can see I sort of Dopplered it out in the midline there. Okay, the groin flap is versatile and it's forgiving. And this is an example where it was a reconstructive issue, but this groin flap and this obese patient who was probably smoking, it croaked distally. But what you can do in that setting is you just debride the bad part and advance the flap, and you can salvage a bad situation. The other thing you can do with the groin flap is you can split it distally. So we didn't do a latissimus. I mean, we didn't do a groin flap to start with, but we ended up doing a groin flap, a split distal groin flap to cover the scar syndactyles. And I don't have the post-op picture. I don't have the late pictures, but it worked well. I also did FDS transfers for extensor later. Okay, here's another one. This is a carting room injury. And you just have to trust me. It's not a great, the picture doesn't do the injury justice, but I'll say that everything volar is intact. Median nerve, ulnar nerve, the radial artery was avulsed. Ulnar artery is intact. The first MP joint, the first CMC joint, the radiocarpal and the radiocapitellar joints are exposed. So how would you cover that one?
Only a few things that big, but what comes to mind is the last, which is one option.
Yep.
And then obviously I would probably do some statements with big sort of wash out.
Right.
We do a monstrous ALT. We do some sort of
Yeah, we really only had one donor though with the radial artery.
Yeah.
One donor artery.
Yeah.
Relatissimus would be good, but
Yeah, you can also
Full
take ALT
assessment.
and PFL before.
That needs a full.
well, I'll tell you what we did. We did a rectus abdominis with a fasciocutaneous extension. And based on the inferior epigastric artery, we felt the latissimus was, it could be trimmed, but the rectus we thought would fit it just right. And so here's the donor, and there it is in place. And it was hard to get out of, we never really got out of the zone of trauma. I mean, the zone of trauma was where the radial arterial stump was, but we plugged in there and we got it to fly, covered with split graft. And this was actually published in JHS in '91. We subsequently did middle and ring FDS transfers to the extensors and a humor transfer to get the thumb working. Yes, sir.
You got a key, like for that flap?
I didn't do it. It wasn't an emergency free flap, but I did it. I did it within 3 or 4 days of the injury. I mean, we took him back and forth and debrided him. He'd actually initially presented to an outlying hospital and had primary wound care there, and was shipped in. And then I took him, as I recall, after he was shipped in, I took him to the operating room one time, and then came back and with Chris McClendon, who I think I got involved with your mom, maybe his son, Taylor McClendon. Yeah, that's his father. He's a plastic surgeon. He and I did this together.
Christy Spencer, what's a humor? Don't tell him Dr. Floyd. What's a humor? Something good, but so tell me that. Tell her. Yeah, it's a fun
But you know, in this case, we'd use FDS for tendon transfers. EIP'd been avulsed.
You only got one thing.
So we really had, we had one thing. So, yeah. Okay, so then we've been talking about the latissimus. We know the thoracodorsal pedicle, and we know the gracilis, which can be innervated with the obturator. And this is a dorsal forearm wound, and this was covered with the latissimus with split graft. We could probably anterolateral thigh I'm sure would have worked, a big one. But another good indication for free tissue transfer is a below elbow amputation. This one on the left, I don't have the x-rays, but I actually covered that with a latissimus flap and a skin graft to avoid converting to an above elbow amputation and to improve prosthetic use. And then about that time, Bill Blair and Michael Jones published a case, and then Scott Levin and his crew have published a series of them in PRS in '07. Okay, so I can talk a little bit about vascularized bone grafts. This is you'll see it's a little bit like taking cold in Newcastle, but the properties of bone graft, one is osteoconduction, which is the growth of bone on a surface, guiding the reparative growth of bone and promoting a structural framework. Osteoinduction is the process by which osteogenesis is induced, and it's the recruitment and stimulation of immature mesenchymal cells, osteoprogenitor cells, to form osteoblasts. Osteogenesis is new bone formation by donor osteoblasts and periosteal cells. Then you have the structural support or mechanical strength of bone graft, and vascular bone is living bone with a vascular pedicle. So this is from an article that something that I think some Bass and Peter Waters put together. It was in the Harvard Medical School Ortho Journal. Bone marrow, it has plus minus osteoconduction, +1 osteoinduction, +2 osteogenesis, no mechanical strength, and no vascularity. Bone marrow has plus osteoconduction, plus osteogenesis, plus osteoinduction, just a little bit of mechanical strength and no vascularity. Cortical autograft has plus osteoconduction, may or may not have osteoinduction, plus osteogenesis, double plus mechanical strength, but no vascularity. And a vascularized graft has osteoconduction, plus, osteoinduction, plus, osteogenesis, double plus, mechanical strength, double crush, and plus, and vascular strength, double crush. You'll see this number. This number shows up on tests sometimes. This range, segmental bone defects greater than 6 to 8 millimeters are an indication for vascularized bone, likely free fibula, due to traumatic bone loss, tumor resection, osteomyelitis, or an infected non-union, and biological failure bony healing with a persistent non-union, osteonecrosis, or congenital pseudoarthrosis. This is a question on one of the self-assessment exams that I like the question, but it's comparing vascularized to non-vascularized grafts. And the right answer is vascularized graft has faster osteoblast migration, preservation of biomechanical properties, but no incorporation by creeping substitution, and has greater osteoid formation. Another question, when you're transferring a free fibula and you want to preserve the proximal physis for growth in the child, you base it on the anterior tibial artery and vein. Otherwise, for most cases, the free fibula is based on the perineal vessels. And this is just an example of a congenital radius pseudoarthrosis that somebody tried to bone graft and pin and came back and we treated with this free fibula. What's that?
Can you repeat that for the physis? I've never heard that.
Okay, the physis is vascularized by the anterior tibial artery. So if you're transferring a fibula for growth with the physis, you base it on the anterior tibial artery.
So it'll grow wherever you transplant it.
Yeah, so the physis is perfused, right? And but generally the perineal vessels are used for the structural diaphyseal free fibula.
So in a kiddo, when you wanted to grow with them, you take it on anterior tibial, but otherwise.
That's right. Yeah, yeah. And this is I'm going to talk vascularized tissue for scaphoid non-unions. Is something I don't have experience with, but I think we need to know. And this is an article out of our friends at the Mayo Clinic, and where and this is a question I've seen on examinations. The percentages of donor vessels or vessels perfusing the lateral femoral condyle, 73% is descending genicular, and 27% is the medial superior genicular. And they reported 84% healing following prior surgery with proximal necrosis and humpback. And here we have this group. So so that's why I was bringing Cole to Newcastle, but Eric and Michael are on this, and this is treating taking an osteochondral vascularized graft for proximal scaphoid non-unions. Okay, I'm shifting gears now, and I'm talking about thumb reconstruction. Okay, and Nicola Dani was a Viennese surgeon in the late 19th century, and one of his goals was reconstructing thumbs. And so on your left, he had this osteoplastic reconstruction where basically he'd put a bone graft and wrap it with a flap. And then he did what we call the Nicola Dani procedure, where the hand is actually sewed to the foot as a groin flap sewed to a hand. You develop flow from the recipient site, and then you divide it. So that was and then nothing was done for a few years. But the goals of thumb reconstruction are mobility, stability, sensibility, length, and appearance. Now, right there in the first web graph, you see phalangization. Phalangization basically means deepening the first web and relatively lengthening the skeleton. And then you can see where, this is Dr. Littler drawing, where the MP to the IP, they would do historically osteoplastic reconstructions. So distal to the IP joint, options, primary closure, one of a myriad of local flaps, including Moberg flap, first metacarpal artery flap, innervated, radially innervated cross finger flap, primary closure or wraparound toe flap. And then when you get from the middle of the proximal phalanx distally, then web space deepening, metacarpal lengthening or a toe to thumb, back at the distal metacarpal to the mid proximal phalanx, toe to thumb or osteoplastic reconstruction, and at the trapezial level, pollicization. All right, guys, this is a 34-year-old burn victim, left-hand dominant. The right first CMC joint has some mobility. The left thumb is ankylosed. He does not want a great toe transfer, and he does not want a transplant. So he's extremely well motivated. Any thoughts on approach to this problem?
I would talk about a couple things. Depending how attached it is to his index finger, you talk about an array, which would give it would hurt potentially get more web space. You could also do some sort of orthodoxic thing next to it. But you would probably need some sort of local flat. He's burned all the way to his forearms. On those pictures, I would be hesitant for any distal transfer just based on the severity of the burns. He's probably a lot of his donors aren't. So I would do a local thing. So your web space thing, some sort of thing, or some sort of amputation.
So tell me about that. What you would do with the second ray? Tell me how you would deal with the second ray again.
You could do a ray resection to give them a web space. There is also, you talk about a pulsization. It's less conventional in adults, but that is another option as well. You can put that over.
That's right.
But it depends on him.
So on the right side, we did full thickness skin grafts in the first web and metacarpal lengthening with distraction osteogenesis. I like to put that pin helps direct it, and it also for a while blocks the FPB flexing that MP joint, but it just always seems to flex down when you get the pin out. But and then for the left hand, the dominant hand, an on-top plastic pollicization with a pollicization of the damaged index finger. You increase length and recreate the web, and conservation of usable structures. And one of the people I trained with had a big influence on me. Was he was chief of the plastic hand surgery service at the Mass General, Jim May, and he's a senior author on this. Matt Donnellan's also a friend. Bryant Toth, a cosmetic surgeon in San Francisco now. But they had this procedure. This guy came to see me about 10 years ago, and I remembered this paper. And so there's the advancement pollicization subacutely, and we did full thickness skin graft that web area. And there is the transposed index finger healed to the thumb proximal phalanx. And I used to, when I do metacarpal lengthenings, I'd bone graft them. But now with the osteogenesis from the distraction osteogenesis, I don't bone graft them, but I plate them, and I feel safer with that. That's the voice of experience. I've had one fracture, and so here's the right hand holding my camera cover. You can see you can see him using his left hand to write. You can see him using his right hand to open a water bottle. And this is one of our South Georgia guys who likes to hunt. So this is his using his hands. And then at the trapezial level, the real option is policization. Okay, first web adduction contractures. Fairly simple principles. You release the skin, muscle fibrosis, capsular fibrosis. You really have to release everything down to the first carpometacarpal joint. And then your defect dictates your coverage option. Back in 1959, at Duke, Goldner, and Kleppinger wrote a paper where it's interesting. You know, we take out trapeziums all the time for basal joint arthritis now. In this paper, they talked about excising the greater multangler to mobilize the thumb, but they also talk about you can take the trapezium out to treat basal joint osteoarthritis. But the basic principle is that you can mobilize using a trapezial excision. So how would y'all approach this case? This is an industrial accident. Came to me like this. He did have thenar atrophy. He'd had a motor branch injury, but otherwise his sensation is intact and his thumb is stuck right where you see it.
I think like we said, it releasing like the skin, muscle, and I think after you get the thumb out and seeing it like, so I saw a patient like this in clinic the other day too, and it's like, can they oppose? Like, do their opponents is intact, or is that part?
No, he cannot oppose. Well, he obviously can't oppose when he's like this, but his APB and opponents are out. He had a motor branch injury.
Okay. So then I'd say like to do an opponent's classy at that time, and then there's probably gonna be a soft tissue defect in the web space as well. That
A big one.
Yeah, so I think I've seen people use PIA flaps for that, and I think that they're nice for coverage.
Yeah, that's a good idea. Anything else?
Either PIA or radial form. We'd also use full thickness skin graft.
I don't think he wouldn't have. I can tell you his bed after he was out, it was too much skeleton there for a full thickness skin graft. I mean, that's good in many cases, but it wouldn't have worked in this one.
Then you get a more complicated stuff.
Well, I wanted to do a lateral arm flap, and so it's based on the posterior branch of the radial collateral artery, which this diagram on it's not a branch of the brachial artery, it's a branch of the profunda brachial, and yeah, there it is there. And I did a primary EIP opposition transfer at the same time. He was so unstable after well, I took his trapezium out as well, and I pinned him in this position, and it was there are a variety of ways to fill that defect. I think that some flap was required. I just pinned it. I pinned the I just went, as I recall, and looking at the pictures, I think I ran that cursional wire straight down the first metacarpal down into the skeleton proximal to the trapezial space.
But there's no formal.
No. I just took the trapezium out for mobility, and I did a Mills hematoma arthroplasty. But there you go.
You were extra somebody like that?
That would have been a good idea, but I'll tell you, once I got him released and got that good flap in, he was just as, I wasn't really worried about it. Michael, you've seen all these before.
My wife texted me, she's like, "Release the cabin flap, nothing,
Okay.
so
Is that
yeah, that's like, better go.
Yeah, you better go. You better go. Yeah, thank you. Thank you. It's okay if I keep going, right, Eric?
Yeah, this is.
Okay.
You sure you don't want to go to the grave? Come help.
I was born there, but I don't want to go back. I'll go down and scrub during the mornings. In the early 1960s, Harry Bunke, who was a plastic surgeon at Stanford, in the garage of their house, did a great toe transfer on a rhesus monkey. Don't you like the term immediate Nicola-Dani procedure? And then in 1973, he published a single case of great toe transfer. You read the case report. The patient required thrombectomy at 48 hours. So even that could give you pause. And here, let's see, this is Dr. Littler, and this is Bob Chase. Bob Chase was Littler's first fellow. He and Adrian Flatt were the first two fellows, and I was one of the last. This is Jim May taking notes, and there's Joe Murray, who we mentioned earlier, doing the did the first kidney transplant. It's back in the audience. Let's see. Carl Hartramp's back in the audience somewhere with a beard. Okay, now, so with great toe transfers, an important point is where's the artery perfusing the great toe? And this you'll see this question on test. Okay, and 70% of the time it's the first dorsal metatarsal artery. 20% of the time it's the first plantar metatarsal artery, and 10% of the time they're the same caliber. So you begin your dissection in the first web. We do fewer and fewer lateral arteriograms. Years ago we did them, but you can pretty much figure it out with a dissection and a Doppler where the vessel is. So this is a explosion victim who had lost his thumb and index finger. Really didn't have much of a hand with the three fingers there. Did a hand arteriogram because of his injury, and found that he did have a thrombosed ulnar artery, but a good artery to the thumb to graft to. So this was my first case, my first toe to thumb. I'd come up here to Grady and took a course on using the 3M coupler. So I used it on the artery on this case. And it clotted off about 4 a.m. And so I came in and revised it using probably 9/0 suture, and I've never used a coupler since then. Probably I should, but I haven't. Okay. And this is another great toe transfer. This was a burn victim. The high voltage power wire he was working on entered his right thumb and exited at his left ulnar nerve. He was shipped to a burn center, and they kept him alive and cared for him. And then he came back to me wanting a great toe transfer, and that was done, as you see. And then there's a wraparound flap that the group in Melbourne popularized, Morrison and O'Brien. It's basically a fillet of the thumb based on the described vessels. It's wrapped around a bone graft, often from the iliac crest. And this is actually not my case. This is Jesse Jupiter's case. But this patient had a dysesthetic thumb tip and got a excellent result with that approach. So we kind of come full circle on the thumb. This is Littler has a paper on making a thumb, 100 years of surgical progress. So we start with Nicola-Dani here. We end with O'Brien and the wraparound here. We've got Monkey here. Finney. All right.
Even it's just hard.
Right. Yes, sir.
I have a million questions, so I'll try.
Let's hear them. Good.
First, replants. A couple things that happened recently. We've had distal targets where we're not allowed, or we can't get info approximately. It can be a relatively straightforward injury. The time is reasonable, but we'll cut back the, say, the digital vessels 3, 4, 5 centimeters, and it's not pulsatile bleeding. I don't really understand why that is, and I haven't found anything that's made that recoverable. I don't know if you have any tips or tricks for establishing inflow as a proximal source.
In the digital artery.
Digital arteries of Palmer are like.
Yeah, I mean, you know, a Fogarty catheter or papaverin. Have you used papaverin?
Not
Do you
intraarterial.
Yeah, do you inject it?
No. Just use it topical, and when you put it on topical, it really makes the nerves and the adventitia just sort of light up, and you can do a nice adventitia stripping or removal, just like a digital artery sympathectomy. Other than those 2 points, and making sure there's nothing on the proximal arm, and making sure the blood pressure is not too low, I don't have any.
That's sometimes it's hard. It's just one of those frustrating things. We've had like a couple, even Christy and I, that it seems like you should be able to get it to work, and like the cut is basically clean.
Yeah. Well, you know, it may be a smoker. It may be somebody using cocaine.
Can you comment on the smoking thing? Because they were smokers. Because that's the only thing I just want to make sure we're not talking up to that.
Oh, I mean, you know, I've seen, you know, I was at Emory when Tom Whitesides first did the work with smoking and failure of spinal fusions. And it's just, that groin flap I showed you, that crump, that was a smoker. And it's just, it's nicotine is bad on the microvasculature. And I think that's a big component. Another thing that you could try, if it wasn't done already, would be, you know, a sympathetic, you know, make sure they're under some type of block. Yeah.
I guess in my mind, it makes sense when there's like an actual like arterial injury, like it's like part of the zone of injury to like cut back on the artery. But in these cases, like the artery like externally really didn't appear like it was like damaged from the trauma. It just had like a lot of like atherosclerosis and like just didn't have.
Well, if it has atherosclerosis,
like it was like, should we like cut back to like something more proximal and do some like large vein graft for something that has like someone who has atherosclerosis in their like digital vessels? Like I don't know.
I think if they have atherosclerosis, it would have to be a thumb or a transmit for me to really want to do it. It have to be a real good reason to do the replant. Yeah.
Because we've had a couple of their fingers and like one finger will work and then the other finger. We don't attempt it because we try for an hour to get it to bleed. You know,
Yeah. I mean, I you know, when you get in there and you see atherosclerotic vessels, particularly in a smoker, just kind of punt. I mean, you can try it, but it's not, the odds aren't good.
Fails, it's not surprised.
That's right.
Could you comment on your approach to skeletal fixation in replants and if it's changed with experience?
Yeah. Well, one, it depends on the level. At the metacarpal level, I would plate, except you see in that small girl, I use K-wires in each one. The thumb I showed, the distal thumb, is just a single longitudinal K-wire. I used to do for digital proximal phalanges perpendicular stainless steel twisted wires. Yeah. You know, I want to use something that's effective and quick.
And then are you convinced there's any big difference in the fixation, like as long as it gets its effective symbol?
I don't think there's that big a difference. I mean, as long as they're not grossly unstable.
And go ahead.
I have a question about, it was a case we did recently and it was like kind of a convulsion type injury to the thumb. And all of the skin was lacerated, but it was maintained with like the ulnar digital like neurovascular bundle. So like the artery and the nerve were intact, but there was no flow. And FPL was intact as well. So the guy was like sitting like this for like 12 hours, warm ischemia time. And then we like straightened the thumb like immediately as soon as we got to the OR, like papavrin, sympathectomy, warm irrigation. Like, is there anything else? Like, what would you do in that situation? There's like no flow to this thumb. The radial, like,
What was the mechanism? What type, was it a avulsive injury?
yeah, the EPL was like a volved from like
Yeah,
muscle
well,
tendon destruction
yeah.
and like the radial.
You have a ribbon sign in the vessels? Do you know what I'm talking about?
It didn't. The vessel actually like looked okay and didn't feel like I couldn't like feel a clot in there, but like there was no like pulsatility to it, and there was like basically no flow.
Yeah. There's a good article, there's an article in JHS years ago. You came from UVA that Ray Morgan there co-wrote on thumb amputation in rodeo. And it's basically you can't get them to work if they have that zone of injury without avulsion. You're probably not going to get it to work, and you're going to be doing one of these reconstructive procedures.
Would you cut that intact artery, or would you like give it a chance, or like?
Oh, I mean, I wouldn't hesitate to stick it on, give it a chance. Maybe even see if you can get I mean, if it doesn't have inflow, a leech isn't going to attach, but if the artery's in place, you may consider heparinizing and observing, keeping them warm and seeing what happens.
What happened for?
Oh gosh.
So if you don't know,
I don't, I mean, I just would have to look it up. I haven't heparinized a patient in so long.
no problem at all. That's always kind of like a black box.
Yeah, yeah.
On that.
I would get the PTT in a therapeutic level.
Okay, so you would actually fully heparinize.
Yeah, right. Yeah, yes.
Is there a certain number of days that you do that for? I know you said for the leeches.
Well, sometimes I do both.
Yeah.
If I can get inflow with heparin, put the leeches on too. You saw all those good humors the leeches secrete. But you got to be careful. That young girl I showed with thumb replant, she bled down to hemoglobin of 6 before I transfused her.
I had another case that I just saw recently of one of our private guys was doing, and it was an ulnar like bone defects up to the olecranon, and they did like a 6 centimeter free fibula after he had failed like an attempt to do like Mascalet and like autograft with that. So like after he failed this, and like the free fibula got infected, and it was like a non-union on both sides. So like, at that point, like, what would you try to do another? Yeah, would you?
Do you think the free fibula is dead?
Free fibula was not alive.
Yeah.
It did not have a skin cap on it. I'm pretty sure that we cut through the pedicle on our way in, and it was like clotted up and like this.
Well, I mean, I think it depends on whether you think there's osteomyelitis in that fibula.
Yeah.
And if you don't think there is osteomyelitis, then you might consider cancellous bone grafting to each end and plating. May have already have a plate on it. I don't know.
We took the plate off because it was infected.
Yeah, but
Now it's just like.
but now if it's infected, it's you're dealing with beads and debridements, and if you could get the infection clear and the patient's up for it, of course you gotta. How proximal is it on the ulna?
Like it's like up to like we were almost in the.
So a 1 bone forearm's not an option, right? Yeah.
Can you talk about your approach to multiple digit replants? You've obviously done two of them. Right?
Yeah.
Like, there's so much thinking and planning that goes in that case.
Well, I would prepare all the fingers at once. If a finger has a segmental injury, I would put it aside. Probably concentrate initially on the index and middle fingers, then go to the ring and then the little.
So
Just-
you get a radial sided-
Just so you maybe get a 3-point pinch as a goal.
Can you talk about your approach to multiple digit replants? You've obviously done two of them. Right?
Yeah.
Like, there's so much thinking and planning that goes in that case.
Well,
And then you do them structure wise, like, so you do prepare them all, do bony fixation of them all, tendons, and then, or do you do one at a time?
I prepare them all. I have, you can do it either way. I have generally prepared them all, but then after preparing them all, put them on one at a time.
And you put them in the fridge or something in the interim?
Yeah, yeah. Keep them cool, or keep them in the room cool.
Okay.
Usually it's in a bag with ice, in my experience.
Like a slushy machine.
Yeah, Grady.
Yeah.
Grady's got
Like
this-
it's like cardiothoracic.
Yeah, I've used that. I've used those for the cardioplegia.
It's pretty
Yeah.
cool.
Yeah,
I
yeah,
haven't put my friends on that.
Do
yeah.
you think there's any utility in flushing those digits while they wait? Some people have talked about, is it University of Wisconsin solution or something, or it's Princeton solution?
Perhaps. I think there's great. I think flushing with heparinized saline's good.
Yeah.
Yeah. Yeah. I mean, you can really see it on that single digit zone one I showed, how that was significantly shortened. That thumb was as well.
Everything's primary, so there's no. For your leaching, I know it's 7 days, is that, and I,
That's 7 days if they have no veins.
so less if they got veins, and then.
Yeah.
So is that like an hour, or how often are you changing the leeches?
Till they fall off.
Okay, so lots, essentially.
Yeah, well, yeah, I mean, if you, if the leech won't attach, you're in trouble. If the leech attaches and stays there for 24 hours, you're probably in trouble. If the leech attaches and falls off in 2 or 3 hours, big and fat, then you're in good shape.
Okay.
Yeah,
But, and then you do that, so, and when you're weeding them off leeches, so let's say you've got some.
Yeah.
Purples you're leaching. but
yeah.
That's just a judgment thing where you stretch out your leaching. and-
Yeah, I mean, I think I would go every 12 hours, see how they do.
Okay.
Then do well.
And I understand that the questions I'm asking are very great, but everyone does it differently. You've done a tremendous amount of
Yeah.
coffee every time. And then in a similar vein, any pearls for co-transfer, that's a case people might do 6 times in a career. That's.
Yeah, well, the pearls are one, going into the first web and finding the vessels. 2, I like to, well, one, when you're amputating at the foot, I like bevel at the distal end of the first metacarpal, so you preserve the sesamoid metacarpal head. Does that make sense?
So instead of being like a transverse thing.
You bevel it so that the volar, the plantar sesamoid metatarsal is maintained. You make it thick enough so that they can. There's some thinking that helps with weight bearing. I don't know how everyone else does it. I take a good length of FHL from behind the medial malleus, open up the tarsal tunnel, and I like to do the FPL junction in the distal forearm. You may have seen it in the drawing in one of the slides. I like to do the anastomoses with the tourniquet up, and then let it down and let it flow. Do the artery deep to the extensor pollicis longus. Hope you have a good vein. Don't, be prepared to wait and wait and wait after you let the tourniquet down and the toes separated to perfuse. And don't, just like with any flap, and don't do your transfer until you've got good flow at its donor site.
Okay.
So
that can take a minute to think up after you did
it can
that.
take 30 minutes.
Okay.
Go drink a cup of coffee.
I'm glad
and
we
come
did
back.
that The first time I do it.
Yeah, right. Well, I mean, go have a cup of coffee, And, I mean, or sit there and bathe it with warm saline.
But, so you do the toe, let the tourniquet down, let that sit for 30 minutes, then you would go.
You let that sit long enough so you got robust capillary refill and blood flow to the toe.
Okay, and
Right.
don't look at that happy.
Right.
For body reconstruction, do you have any set protocol for your activate, like when you're doing the osteoplastic, and like together? How long does that take? You know, obviously depends on like.
Wait, what do you, oh, that lengthening?
Yeah.
You do you put on the expositor, you do a corticotomy.
Okay.
And you let that sit for about a week.
Okay.
And then you distract it. I usually distract it 1 millimeter in the morning and 1 millimeter in the evening.
Okay.
And do that for about a month. Okay. Which would maybe actually.
Maybe half that or something.
Yeah, no, I would do it for about 4 weeks, but I'm not sure. I have to think that through. I think 1 millimeter, half millimeter twice a day.
Okay.
And
Use
do
a millimeter.
and do that for 30 days. That will get you 3 centimeters. And then let it sit there for as long as the pin sites are healthy, maybe another 4 to 8 weeks to let the new bone, and you can follow it radiographically. And when that happens, I take the fixer off and put the plate on.
Okay, and you plate it just prophylactically because that bone's not necessarily strong.
That's right. As I said, I've had a case that I did the distraction osteogenesis, and it fractured, like 2 or 3 weeks out, as I recall. I went back and plated it, and it did fine. And since then, I've plated them. Whereas early in my career, I'd distract them out and put cancellous autograft in there.
Mm-hmm. Okay. And so when you take out the X-fix, you just do a dorsal approach and put a plate on.
Yeah, that's right. Mm-hmm.
And then one thing I've seen kind of variability on in terms of large bone defects, almost what Chrissy was talking about, there seems to be 2 camps. Some people will masculate these monsters.
I think masculate's changed so much since I love masculate. Okay. I also like masculate technique in the hand when you have joint infections, septic arthritis. Go in, debride to healthy bone, put in the vancomycin impregnated spacer, leave it in, come back, bone graft it. It's a good technique. Mm-hmm. But my brother is a orthopedic trauma surgeon, and he uses masculate for big. Yeah, that's right. Yeah.
Okay, so it's still an excellent option, because I know that 6 to 8 centimeters comes up on tests, and I've definitely seen people masculate stuff like that.
I'll tell you what, I've bone grafted an ulnar defect that's 8 centimeters long, with cancellous autograft on a plate, and it worked just fine in a young, healthy person.
Yeah. So it depends on the protocol of the mechanism.
Right. Young girl from Dublin, as a matter of fact.
How long ago?
This was 10 or 15 years ago. Car accident victim. Yeah.
And then in terms of arterial reconstruction, I've seen people either do saphenous vein for like a major artery of the forearm. What's your opinion on like an arterial autograft versus venous autograft?
Well, all my career, I've done venous autografts. But I have had, particularly when treating ulnar artery thrombosis. I'll tell you when you see the ulnar artery thrombosis cases, the first cold snap of the year they come in. And I have several of them that have developed aneurysmal changes with the vein graft. The only one that I've ever revised was the one I mentioned, and I was very happy. The arterial graft, took care of the problem. It worked well. And I think that the best of all possible worlds, arterial graft. I mean, that's the heart surgeons. They take our radial arteries, but But the donor, their donor issues going, I'm telling you, when you go to get that artery here, so it's an incision like that. But I do think that for arteries do well.
I did it once for like a hip type of
Yeah.
situation, and it was really nice because the arterial like disease would help reach confidential, and you can use the branch of to like reconstruct with like digital branches as well as opposed to like
Yeah, I think to answer the question, and you alluded, you made the point, is if I was doing like a ulnar artery thrombosis, hypothenar hammer syndrome, if one came in tomorrow, I would use an arterial graft.
Okay, because I've done those with saphenous and it seems fine, but we never.
The saphenous works, it flows for years, but a certain number of them will balloon, and they'll walk in and put their hand there, and it looks like an AV fistula in their palm.
I haven't, no, I'm just not. Yeah, that makes sense.
But they just have to know they're gonna get a whack on their thigh just to get them to get it.
Oh yeah, guys,
It's
a
like
big,
an ALT
Yeah,
incision.
basically,
It's
I
like-
imagine
Yeah.
an ALT without an ALT.
right. I mean, the other option is, going up top and getting thoracodorsal.
That would
Equally
make
want
Dr.
that.
Wagner really sad, because
Dr.
he wants
Wagner.
the logistmus to be happy.
He's a friend of the.
So I'm just pointing out points that when you split isthmus as he's losing you,
You probably get three of
no
them.
reason to take the whole thing, and that functionally, your shoulders are actually much better.
Dr. Green's counterpoint.
The lift is actually fine, I think the door.
It's called the secondaries.
He likes all the others as well.
Yeah. So that, Yeah.
That's actually the biggest thing, like that's when you have to roll them.
Yeah.
Or like a parastatic first.
Yeah. that serratus flap, that was a workers' compensation case that I ultimately had to rate. And I was being deposed on it. And they asked me, what was this rating I put in for long thoracic nerve paralysis? And I said, man, that's because I took the muscle it goes to. And the patient did have scapular winging.
It is what it is.
That's what it is. That's right.
You get what you get.
That's
as
right.
Dr. Dempsey would say.
So that is correct.
Yeah.
Dr. Nahai used to like serratus. Talk about it.
Dr. Who?
Dr. Nahai.
Oh, yeah. Yeah.
Serratus, just taking a few slips at it and trying to fit it.
Well, I did free flaps with him when I was a medical student. In fact, the first latissimus I ever saw, Dr. Nahai did at Emory. Yeah. Actually, it was at Crawford Long. Yeah.
That's where I heard the serratus from.
Yeah.
But I've always wanted to do one. I just haven't.
I'll tell you, at Emory, the plastic surgeons at Emory in the 80s under Dr. Yurkewitz, it was phenomenal things happening every month. It was really something.
Yeah.
Yeah.
Do you have any pearls of wisdom for major nerve injury in the upper extremity?
Major nerve injuries in the upper extremity.
Because you've shown a lot of pictures with like major skeletal, and I'm sure the nerves aren't normal and all those.
Yeah. One, when people say you get the best results when a nerve is free of tension, that's just absolutely true. And if you ever graft a major mixed nerve, just put those nerve grafts in so they're just sinusoidal, like snakes in there, and absolutely tension free. I'm sort of I've supercharged. I've end-to-end AI to ulnar motor. That's a lot of little nerve fibers in the recipient, not near as many in the donor. And I think the jury's still out on that. There was a paper in JHS not long ago, it was from out of the country somewhere, on the failure of the AI to correct clawing. But I do it. I mean, I had I had a lady last week who had one of these contraceptive implants,
They hit it.
and the OBGYN had gone in trying to get it out, and the patient developed ulnar paralysis, and she was like 28, and I was all set to explore the nerve, do it, graft it, whatever, and do. At 28, I thought I would do the supercharge, even though it's above the elbow, the supercharge and not the end side. I got in there as a big old pseudoaneurysm of some unnamed, but it was more of a venous aneurysm, but just a big old clot inside a dilate. And so I took that out, and I saw her this week, and she'd gotten back a little finger FDP, so maybe she'll get back. Yeah. So, and I got that damn implant, the contraceptive implant out.
That kind of created another problem.
Yeah, well, I consented her for it.
That exact case was met at AHS.
Oh, really?
Yeah, 2 weeks ago, that they showed this little cut here.
Yeah.
I can't remember what they hit. They hit like LHC.
Oh, really? Yeah. Yeah. There's a case in the literature. I looked it up where they had to nerve graft one. Yeah. It's but just tension free. I think I have no confidence in, and I'd love to be challenged until I'm wrong, but I have no confidence in nerve allografts for motor nerves. You agree with that? Good. Yeah.
We'll use them for digital sometimes.
I'll use them for digital, for 4 or 5 millimeters, that type of thing.
Instead of doing hand or something. Just 'cause it's
Yeah,
easy.
right. Expensive though.
That is.
Question, it was like somebody had like isolated like PIN laceration that was like 4 centimeters, and the answer was like, what percent of patients would get like M4 if you allografted it? And it was like 80% of them.
If you allografted or autografted?
Allograft.
Allograft didn't work for action.
Yeah,
It
right,
worked
right.
for
Well-
accident.
Don't work for action. Surgery doesn't work for
Well,
action.
Well, the answer to the question is, because I know, because I was involved in a case recently that I reviewed. If you have a PIN injury and you autograft it, and it's before 6 months, 85% chance you'll get M4 function.
That answer can't be the same.
That's a paper in microsurgery by that Nunley's own.
I know.
Yeah, but whoever wrote that question's wrong. That one should get that. I'm sure they got wrong.
Great.
Yeah.
Could you talk about secondary flap thinning? And a lot of, we see the acute phases, and then you've got great results. And if that happens in one go, please tell me how you did that in one go.
The only, of course, I've secondarily thinned multiple groin flaps, and you just gotta keep the 1-to-1 ratio in mind. You keep the base width to length at 1-to-1, and you get one side, and then you can come back. I guess in these days, they could be liposuction, but I have no experience with that. I've defatted, I've thinned lateral arm flaps, and I really think once the lateral arm flap's on there for a while, you can treat it like the groin flap, using the 1-to-1.
And just direct excision of whatever you don't like.
Yeah, right. That's really my experience with lateral arm flaps and groin flaps.
Do they get angry looking after you thin them? Or should they be pretty physiological the whole time?
I've never seen them get angry.
Okay. Some flaps like reverse radial forms, sometimes it's purplish for a period of time.
Yeah, what are you talking about? After you don't thin them until they're mature, and after they're mature, as long as don't close them under tension, and you maintain a 1-to-1 ratio, they maintain good flow.
So you leave half of your, basically half of it attached, then half, put that back down, come back.
Come back a few weeks later and do the other side. Yeah.
And then you can aggressively thin them.
Yeah, you can thin them as deep as you want, as long as you maintain the 1-to-1. I mean, I wouldn't go through the dermis, but up to the dermis, yes.
It was really cool.
Oh, thank you.
Thanks
Thank
for
you.
sharing those cases.
Absolutely. I enjoyed it.
What's the wildest replant you've done? I know your proudest one is that little girl, but
Well, that's the wildest one I've done because her grandfather, who was an esteemed neurosurgeon, had a helicopter taking her to Atlanta, turn around and bring her to me. And it was just a lot of pressure.
understandably so.
And her uncle was a neurosurgeon too. So it was, I mean, that just is the wildest one I've done. That's still the wildest one I've done. 4-year-old girl. And you see the result. And I had to take her back. It crumped, she bled. I would have to, of course, that kid I showed that I did with the scrub nurse, that was pretty, that was an awesome case, you
Did you
know.
arterially shunt that during the case, or did you just like fix it best method?
I did not arterially shunt it. I plated it, and I harvested the Southwest vein myself. No PA, nothing, no, harvested the Southwest vein. I'd worked for heart surgeons a long time, and I knew how to do that. And then just did the repairs, got it done.
Not a bad idea.
The shunting's a great idea.
Well, there's a shunt that's our full shunt on. We have.
Shunting would have been, it's a great idea, but I didn't do it.
It worked anyway.
Yeah.
Any experience with orthopic? Like,
I have no experience with that, but I think it's pretty cool.
Yeah, because I've always seen pictures, and I hope the first time, if I never have to do it, that's okay. But I don't even know where I put digits.
I don't know about digits, but I think if you had like one of these hemi hands or hand at the wrist, and there was a medical reason why you couldn't put it on, then that banking it in the groin's a good idea.
So you'd find a CIA, plug that in.
Yeah. Yeah. That's,
Yeah.
but I've never done that.
But I've never done it either. Like, there's gonna be a time, and if I'm by myself, like I would like to at least thought of it once.
Did you do hand fasciotomies for that kid that had the transhumeral amputation, or did you just?
You know what? I was thinking about that driving up here today, because I did not.
When they were.
I opened him up from the, I did, you know, just a standard fasciotomy, but I did not do, to my, I don't think I did interosseous hand fasciotomies on him. You know, looking back on it, I got away with it, but I probably should have.
You would like.
There's no harm in doing that.
No harm in doing it. Probably should have done it.
I've worked with different split ideas. Some people say you can't get it. Some people say,
But you see, the thing about it is, when I did the fasciotomy, the point I was trying to make, at that point, there was no compartment syndrome.
Right.
It was a prophylactic fasciotomy for reperfused muscle.
And then, is there any major differences in your mind dealing with small amputated parts versus big amputated parts? Things you would change? We see a lot of digits, but we don't see a lot of hands that form.
Well, you know, the only thing is, you know, there are issues, metabolic issues associated with dead muscle. So that's one issue. But other than that, as long as you follow the principle of shortening, the proximal ones are a lot easier.
Less stuff, bigger stuff.
Yeah.
In somebody who like had like more than 6 hours of form ischemia time, would you still try to like put the part back on? Like still try, right? Like.
Yeah. Yeah, I mean, that's, I agree. Yeah.
Well, it was like the stuff that we were doing, like it was still attached.
Oh.
So it was like the work ischemia time was like 12 hours, but like it's alive. So
So we're just really kind of like do that, when it's still attached. It's 12 hours.
And then have you ever done just like a vein only replant of anything? Like like this guy that with the thumb, I just like fixed 2 dorsal veins and like I didn't know what else to do, so.
I've done veins only on ring avulsion injuries when they had perfused arteries. And then I showed that case where I couldn't do a vein, so I leached
Holy shit, yeah.
and then covered with the reverse cross finger. But that, I can think of one case that was kind of dorsal degloving with palmar intact that I vein grafted. But if the veins are there to graft or to do, it's,
That was just from proximal like inflow.
There was no inflow, but the ulnar artery was impacted, the radial side was like bulged out, like of the palm. And so like, we did like symphyctomy, and all this stuff, and feel like there was a clot, but there was like never any like motility to the vessel. And there was like,
The radial artery proximal or wherever.
we didn't go, well, I mean, the ulnar digital artery was intact. Correct, but like, it had been like flexed down like this, because FPL was intact too,
Yeah.
so it was like kinked for 12 hours.
wow.
Do you do a lot of zone one replants? Like, is that like an easy thing or?
I haven't done a lot of them. I don't think there are a lot of them to do, frankly. I mean, this series out of Duke was, I think they had 40 cases, but that was a regional referral when there were a lot more industrial